Hi everyone, welcome back to the channel. Today we're covering one of the most crucial skills in medicine, interpreting laboratory data. We'll walk through the common categories and decode what abnormalities could mean. Let's get started. First up, the complete blood count or CBC. This includes hemoglobin, white blood cells, and platelets. The normal values of hemoglobin in adults typically range from 13 to 18 grams per deciliter for men and 12 to 16 grams per deciliter for women. If hemoglobin is too high, a condition called polycythemia, we ask, is it primary, secondary, or relative? To answer this, we need to look at the EPO, or erythropoietin level. It's a hormone made by the kidneys that tells the bone marrow to make red blood cells. If the EPO is low, that tells us the bone marrow is making too many red blood cells on its own, without any external trigger, seen in primary polycythemia, like polycythemia vera. If the EPO is high, it suggests that the body is sensing low oxygen and trying to compensate by making more red blood cells. This happens in secondary polycythemia, caused by things like chronic hypoxia from lung disease, living at high altitude, or tumors that secrete excess EPO, like renal cell carcinoma. If the EPO is normal but hemoglobin is still high, the cause is usually relative polycythemia, meaning there's no true increase in red blood cells, just a decrease in plasma volume, as seen in dehydration or stress-related hemoconcentration. When hemoglobin is low, we know the patient has anemia, but to figure out the cause, we look at the MCV, or mean corpuscular volume, which tells us the average size of red blood cells. The normal range for MCV is 80 to 100. In microcytic anemia, the MCV is below 80, meaning red blood cells are smaller than normal. This usually happens when there's a problem with hemoglobin production, especially with the heme or iron part. Common causes include IDA or iron deficiency anemia, often from blood loss or poor intake. Thalassemia, a genetic defect in globin chain production. Sideroblastic anemia, a condition in which iron can't be used properly to make hemoglobin. ACD or anemia of chronic disease, where inflammation traps iron in storage. In normocytic anemia, the MCV is between 80 and 100. The cells are the right size, but there just aren't enough of them. Common causes include chronic diseases like CKD or heart failure. Aplastic anemia, where the bone marrow fails to make enough cells. And hemolytic anemia, where red blood cells are destroyed too quickly. In macrocytic anemia, the MCV is above 100, meaning the red blood cells are larger than normal. This typically results from impaired DNA synthesis, which causes the cells to grow but not divide properly. The most common causes are vitamin B12 and folate deficiencies, often due to malnutrition, alcoholism, or malabsorption. Now let's move on to white blood cells. The normal count ranges from 4,000 to 11,000 per microliter. A high white blood cell count doesn't always mean infection. It depends on the subtype. If neutrophils are elevated, think about bacterial infections, acute inflammation, steroid use, or even a stress response. If lymphocytes are high, it points more towards viral infections or possibly lymphoma. An increase in eosinophils suggests parasitic infections or allergic reactions. And elevated monocytes could indicate tuberculosis infection, autoimmune disease, or chronic myelogenous leukemia, abbreviated as CML. On the flip side, a low white count, leukopenia, might result from medications like clozapine, antithyroid drugs, chemotherapy agents, and immunosuppressants. Normal platelet counts range from 150,000 to 400,000 per microliter of blood. High platelets or thrombocytosis may be reactive due to inflammation, infection, or anemia, or they may be a primary bone marrow disorder, like essential thrombocythemia. Low platelets or thrombocytopenia can result from a few different mechanisms. One is platelet destruction. This includes conditions like ITP, which stands for immune thrombocytopenic purpura. It's an autoimmune disorder where the body produces antibodies that destroy its own platelets. TTP, or thrombotic thrombocytopenic purpura, is a rare condition where small clots form in blood vessels throughout the body, consuming platelets and leading to low blood counts. HUS, or hemolytic uremic syndrome, is often triggered by E. coli infection, which causes red blood cell destruction, kidney injury, and low platelets. DIC, or disseminated intravascular coagulation, is a serious condition where widespread clotting in small vessels uses up both clotting factors and platelets, causing both thrombosis and bleeding. On the other hand, decreased platelet production often doesn't happen in isolation. It usually co-occurs with pancytopenia, meaning red blood cells, white blood cells, and platelets are all reduced. This is because the problem lies in the bone marrow itself, where all blood lines are produced. Bone marrow problems can be caused by autoimmune diseases, viral infections like EBV or CMV, chemotherapy, or leukemia. Pancytopenia can also occur in hypersplenism, in which the spleen becomes enlarged and starts sequestering blood cells, basically trapping them instead of letting them circulate. Now let's look at the basic metabolic panel, or BMP, which helps us assess electrolyte balance, renal function, and glucose control. Normal sodium levels range from 135 to 145 milliequivalent per liter. When sodium is elevated, it usually reflects a loss of free water rather than too much sodium intake. Some important causes include dehydration, where the patient loses water through vomiting, diarrhea, fever, or simply poor intake, especially in the elderly. Diabetes insipidus, where the body lacks or doesn't respond to the antidiuretic hormone, or ADH, which usually concentrates urine. Hyperaldosteronism, where excess aldosterone causes the kidneys to retain sodium and excrete potassium. Iatrogenic causes, such as hypertonic saline or sodium bicarbonate infusions, often seen in ICU settings. On the other hand, when sodium is low, it usually means there is too much water relative to sodium. Some common causes include SIADH, or syndrome of inappropriate antidiuretic hormone secretion. Here, excess ADH causes the kidneys to retain water, diluting the sodium in the blood. It's commonly seen in lung disease, brain injury, or as a side effect of medications. In heart failure, cirrhosis, and nephrotic syndrome, the body perceives low effective blood volume and holds onto water, again diluting sodium. Normal potassium levels are 3.5 to 5 milliequivalent per liter. When potassium is elevated, called hyperkalemia, it can cause arrhythmias, and it is often due to acidosis, in which hydrogen ions move into cells, pushing potassium out. Renal failure, where the kidneys can't excrete potassium effectively. Cell lysis, such as hemolysis, rhabdomyolysis, or tumor lysis syndrome. Hypoaldosteronism. And drugs like ACE inhibitors, ARBs, potassium-sparing diuretics, or NSAIDs. When potassium is low or hypokalemia, it may be due to GI losses from vomiting or diarrhea, alkalosis where potassium drifts into cells, diuretics, especially loop and thiazide types, insulin which drives potassium into cells, and hyperaldosteronism, which promotes potassium excretion. Now let's move on to BUN and creatinine, two key markers we use to assess kidney function. BUN, or blood urea nitrogen, comes from the breakdown of protein. Protein is metabolized into ammonia, which gets converted in the liver to urea, then excreted by the kidneys. So BUN levels depend on protein intake, liver function, and kidney excretion. Creatinine, on the other hand, is a waste product from muscle metabolism. It's produced at a relatively steady state and is mostly cleared by the kidneys, making it a more direct indicator of glomerular filtration. If only BUN is elevated but creatinine is normal, it's often a pre-renal issue, like dehydration, a high-protein diet, or gastrointestinal bleeding. These all increase nitrogen load or reduce kidney perfusion, but without intrinsic kidney damage. When both BUN and creatinine are elevated, it usually points to renal or post-renal causes. Renal causes mean there's damage within the kidneys themselves. Examples include ATN or acute tubular necrosis, often due to ischemia or nephrotoxins, GN or glomerulonephritis, from autoimmune or infectious inflammation, AIN or acute interstitial nephritis, usually drug or infection-induced, and CKD or chronic kidney disease. Post-renal causes refer to anything that blocks urine flow after it leaves the kidneys, such as BPH or benign prostatic hyperplasia, kidney stones, and tumors. These obstructions cause urine to back up, increase pressure inside the kidney, and eventually reduce function. When BUN and creatinine are both low, it's usually not from kidney disease. It can happen in overhydration, where blood is diluted, in liver disease, where the liver isn't producing enough urea, or seen in low muscle mass, especially in elderly or malnourished patients, reducing creatinine production. Next up in the basic metabolic panel is glucose, which reflects how the body is managing blood sugar, a critical source of energy for cells. The normal fasting glucose is around 70 to 100 milligrams per deciliters. Elevated glucose can result from a number of conditions, most commonly diabetes mellitus, where insulin is insufficient or ineffective, Cushing syndrome, where excess cortisol increases glucose production and promotes insulin resistance. Certain medications, like glucocorticoids or beta agonists, can raise glucose levels. Pheochromocytoma, a tumor that secretes epinephrine, also increases blood sugar. Stress hyperglycemia, seen during infection, trauma, or surgery, may also induce cortisol release, thereby increasing blood sugar. On the other hand, common causes of low glucose or hypoglycemia include overdose of glucose-lowering medications, like insulin or oral agents such as sulfonylureas, abbreviated as SUs, and meglitinides. Other causes include insulinoma, a rare tumor that secretes insulin inappropriately, causing recurrent hypoglycemia, sepsis or critical illness which increases glucose consumption and impairs production, fasting, especially in malnourished or elderly patients with limited glycogen reserves, adrenal or pituitary insufficiency, where low cortical levels impair gluconeogenesis and reduce glucose availability. Note that both CBC, complete blood count, and BMP, basic metabolic panel, are some of the most routinely ordered blood tests in the hospital. Whether a patient is coming into the ER, being admitted, or just having pre-operation labs, these two panels are almost always part of the initial workup. Let's move on to liver function tests. These include multiple lab values that reflect different aspects of liver health, including hepatocellular damage, bilirubin metabolism, and liver synthetic functions. AST and ALT are liver enzymes that are released when liver cells are damaged. ALT, which stands for alanine aminotransferase, is more specific to the liver, while AST or aspartate aminotransferase is also found in the muscle, heart, and kidney. When AST is greater than ALT, especially with a ratio over 2:1, it strongly suggests alcoholic liver disease. This is because alcohol damages mitochondria, where AST is more concentrated. Other conditions that may show AST greater than ALT include advanced cirrhosis and liver malignancies, where hepatocyte function is severely reduced. On the other hand, when ALT is greater than AST, that usually points to direct hepatocellular injury, such as viral hepatitis, non-alcoholic fatty liver disease or NAFLD, drug-induced liver injury, autoimmune hepatitis, Wilson's disease, or ischemic hepatitis. Next is hyperbilirubinemia, or elevated bilirubin in the blood, the key lab finding behind jaundice. To interpret bilirubin elevation properly, we need to understand its pathway. Bilirubin comes from the breakdown of hemoglobin in red blood cells. It starts as unconjugated or indirect bilirubin, which is water-insoluble and carried to the liver by albumin. In the liver, it's converted by UGT enzymes into a conjugated or direct bilirubin, which is water-soluble and normally excreted into bile. Hyperbilirubinemia can thus be classified into indirect and direct, based on the proportion of conjugated bilirubin in the total. Indirect hyperbilirubinemia is defined when direct bilirubin is less than 20% of the total bilirubin. This means most of the bilirubin in circulation is unconjugated, and the problem lies before the liver has processed it, what we call prehepatic causes. Common examples include hemolysis, where red blood cells break down rapidly, and genetic defects in conjugation such as Gilbert syndrome and Crigler-Najjar syndromes. On the other hand, direct hyperbilirubinemia is defined when direct bilirubin makes up more than 20% of total bilirubin. This indicates that bilirubin has already been conjugated by the liver, but cannot be properly excreted, either due to hepatocellular damage or biliary obstruction. This includes both hepatic causes, usually accompanied by elevated AST and ALT, including hepatocellular injuries mentioned above, such as hepatitis, cirrhosis, or drug-induced liver injury, where conjugated bilirubin leaks back into the blood, and post-hepatic causes that block bile flow after conjugation, showing a cholestatic pattern. They are typically associated with elevated ALP and GGT. Common causes include gallstones, tumors, or primary sclerosing cholangitis, abbreviated as PSC. In these cases, conjugated bilirubin is trapped and backs up into the blood, leading to symptoms like jaundice, dark urine, and pale stools. Another critical job of the liver is synthesis, making essential proteins for the body. We evaluate this with two main lab values, albumin and prothrombin time, or PT, which measures the extrinsic coagulation pathway, including several vitamin K-dependent clotting factors produced by the liver, and the International Normalized Ratio, INR, which standardizes PT results across different labs to make them comparable. Albumin is the main plasma protein synthesized by the liver. It helps maintain oncotic pressure and transports hormones, fatty acids, and drugs. If albumin is low but INR is normal, the liver is likely still functioning. This pattern usually points to malnutrition, chronic illness, or protein loss, but not liver failure. But if albumin is low and INR is prolonged, that suggests the liver is failing to synthesize proteins, including clotting factors, seen in liver failure. INR can also be prolonged in warfarin use, which inhibits vitamin K recycling, and vitamin K deficiency, due to poor intake or fat malabsorption. Now that we've covered PT and INR as part of the liver's synthetic function, let's look at the broader coagulation panel, which gives us more information about how the body handles clot formation and breakdown. In addition to PT-INR, we assess the APTT, which stands for Activated Partial Thromboplastin Time, for the intrinsic pathway. Common causes of prolonged APTT include heparin therapy, inherited coagulation factor deficiency such as hemophilia and von Willebrand disease, abbreviated as VWD, and antiphospholipid syndrome, or APS, an autoimmune condition where antibodies interfere with phospholipid-dependent clotting assays. When both PT and APTT are elevated, we start thinking about global coagulation disorders, where multiple clotting pathways are affected. Two major possibilities include advanced liver failure, where the liver can't produce enough clotting factors, and disseminated intravascular coagulation, or DIC, mentioned earlier, a systemic process where the body forms clots and breaks them down at the same time, resulting in low platelets, increased D-dimer, and low fibrinogen. D-dimer is a breakdown product of cross-linked fibrin. Besides DIC, D-dimer can also be elevated in venous thromboembolism, like pulmonary embolism or deep vein thrombosis. It's very sensitive but not specific. Therefore, a low D-dimer is used to rule out these diseases. Let's move on to another important category of lab data, inflammatory parameters, which help us detect systemic inflammation and autoimmune activity. These are broadly divided into two groups. Acute phase reactants are proteins that change in response to infection, inflammation, or tissue damage. Upregulated acute phase reactants include CRP or C-reactive protein, which rises quickly in acute inflammation, infection, or trauma. ESR, or erythrocyte sedimentation rate, which increases more slowly and is often used in chronic or autoimmune inflammation. Ferritin, an iron storage protein. Hepcidin, a hormone that blocks iron absorption and release. Fibrinogen mentioned earlier, and PCT, or procalcitonin, a more specific marker for bacterial infection. Downregulated reactants include albumin, transferrin, an iron transport protein that goes down in inflammatory states, and antithrombin, a natural anticoagulant that may drop in systemic inflammation. When autoimmune disease is suspected, specific autoantibodies help narrow the differential. Key autoimmune markers include ANA, or anti-nuclear antibody, a general biomarker for many autoimmune diseases. Anti-double-stranded DNA and anti-Smith antibodies, highly specific for systemic lupus erythematosus, or SLE. Anti-Ro and anti-La, which are common in Sjogren's syndrome. Anti-SCL70, seen in diffuse systemic sclerosis. Anti-centromere antibody, or ACA, associated with limited scleroderma. Anti-U1-RNP, which is positive in mixed connective tissue disease, or MCTD. An anti-neutrophil cytoplasmic antibody, abbreviated as ANCA, associated with small vessel vasculitis. These markers don't make the diagnosis on their own, but when combined with symptoms and clinical context, they're essential for identifying autoimmune diseases. Let's now move on to microbiology, which plays a key role in identifying infectious causes of systemic illness. The most basic and most important tools are cultures. Samples are commonly collected from blood, urine, stool, sputum, and cerebrospinal fluid, or CSF. In addition to cultures, we often use smears and stains to quickly identify pathogens under the microscope. Urine analysis is a routine but powerful test that gives us clues about renal function, infection, and systemic disease. Serous fluids like pleural, peritoneal, and pericardial fluid are often collected to investigate infusions. Lipase and amylase are pancreatic enzymes commonly used in the diagnosis of acute pancreatitis. Amylase breaks down carbohydrates, and it's found in both pancreas and salivary glands, whereas lipase digests fats, and it's produced almost exclusively by the pancreas. Therefore, it is considered the preferred marker for diagnosing acute pancreatitis. Troponin I is the most specific marker for myocardial infarction. However, it is also elevated in myocarditis, sepsis, congestive heart failure, pulmonary embolism, and CKD. NT-proBNP is released by ventricular myocytes in response to volume overload or increased wall stress. It's a key marker in diagnosing and monitoring heart failure. Higher levels suggest worse cardiac function, but may also be elevated in renal failure, pulmonary hypertension, acute coronary syndrome, atrial fibrillation, and valvular heart diseases. Perfusion refers to how well oxygenated blood is reaching tissues. When tissue perfusion is inadequate, we start to see anaerobic metabolism. And one of the key markers of that is lactate, which is elevated in shock states, sepsis, hypoperfusion, or cardiac arrest. The standard lipid panel includes total cholesterol, which is normally under 200 mg per deciliter, triglycerides, a type of fat from diet or liver metabolism, which is normally under 150 mg per deciliter, LDL-C, or low-density lipoprotein cholesterol, often called the bad cholesterol, which is normally under 100 mg per deciliter, and HDL-C, or high-density lipoprotein cholesterol, often called the good cholesterol, which is normally greater than 40 mg per deciliter. Abnormal lipid profile, or dyslipidemia, is associated with higher cardiovascular risk and should be monitored. Tumor markers are substances that are produced by cancer cells or by the body in response to cancer. Some examples include CEA, or carcinoembryonic antigen, which is elevated in colorectal cancer, AFP, or alpha-fetoprotein, which is elevated in hepatocellular carcinoma and germ cell tumors, CA125, which is elevated in ovarian cancer, PSA, or prostate-specific antigen, which is elevated in prostate cancer, beta-HCG or beta-human chorionic gonadotropin, which is elevated in germ cell tumors and choriocarcinoma, and calcitonin, which is elevated in medullary thyroid cancer. Let's now look at some common endocrine markers, lab values that help us assess hormone function across different glands. Thyroid function is assessed by TSH, or thyroid stimulating hormone, and free T4. Average blood glucose over 2 to 3 months can be assessed by HbA1c, which is not affected by fasting and can be diagnostic for diabetes. Cortisol is the main hormone from the adrenal cortex. Low cortisol may suggest adrenal insufficiency. ACTH helps determine if cortisol issues are primary, which means adrenal, or secondary, which means pituitary. Aldosterone and renin are tested together to evaluate hypertension with hypokalemia. PTH or parathyroid hormone and vitamin D are tested for abnormal calcium levels. Lastly, electrolytes are essential for maintaining fluid balance, nerve and muscle function, and acid-base homeostasis. As mentioned earlier, sodium levels reflects overall water balance. Chloride, bicarbonate, and phosphate help regulate acid-base status. Calcium, potassium, and magnesium are key to neuromuscular excitability, affecting things like muscle contraction and cardiac rhythm. And both calcium and phosphate are critical for bone mineralization and skeletal health. And that wraps up our overview of common lab values. From the complete blood count, basic metabolic panel, liver function tests, coagulation panel, all the way to inflammatory and other parameters. Thanks for watching. I'll see you in the next one.